Hello, everyone, and welcome to today's webinar on taking charge of your LDL cholesterol and improving your heart health. My name is Sue Peshin, and I serve as President and CEO of the Alliance for Aging Research. The Alliance is the leading nonprofit organization dedicated to changing the narrative to achieve healthy aging and equitable access to care. And we're hosting this webinar as a part of our Talk Nerdy program. And Talk Nerdy, Nerdy stands for Nurturing Engagement in Research and Development with You. And it's a program that empowers older adults, family caregivers, clinicians, and healthcare researchers to learn about clinical and patient-centered outcomes research and how we can all work together to answer the questions that matter the most to patients. This webinar is going to focus on empowering all of you to get the information you need so that you can take charge of your heart health and have important conversations with your loved ones and healthcare professionals. And we're excited to be able to bring this webinar to you and would like to thank our generous sponsor, Amgen, for their support. Our speakers today are Dr. Fatima Rodriguez, Associate Professor of Cardiovascular Medicine at Stanford University, and Mr. Hilly Page, Chief Innovation Officer at the Family Heart Foundation. Dr. Rodriguez earned her medical degree from Harvard Medical School and her MPH from the Harvard School of Public Health as a Zuckerman Fellow at the Harvard Kennedy School's Center for Public Leadership. She then completed internal medicine residency at Brigham and Women's Hospital and her fellowship at Stanford University before joining the faculty. Dr. Rodriguez leads an interdisciplinary research program aimed at population-level interventions to eliminate disparities in cardiovascular disease and to promote cardiovascular health. Her contributions to science include documenting racial and ethnic disparities in guideline adherence, personalizing cardiovascular disease risk prediction and prevention, artificial intelligence for opportunistic screening of atherosclerosis, and leveraging digital health tools to improve the care of diverse patients. Mr. Hilly Page, our other speaker, is the Chief Innovation Officer for the Family Heart Foundation. Mr. Page graduated from Vanderbilt with a degree in biology and chemistry. He has more than 30 years of leadership experience in the biopharmaceutical industry, including leading patient and professional advocacy functions, new product franchises, product development and commercialization teams, strategic planning, and launch strategies for products in the cardiovascular and metabolic therapeutic area. At the Family Heart Foundation, Hilly leads the GOAL initiative to engage healthcare practitioners, patients, payers, and policymakers to improve treatment and control of LDL cholesterol in high-risk Americans. He also played a key role in the development and launch of the Cholesterol Connect program, which provides free at-home testing for LDL-C and Lp(a), and you're going to hear more about that today. In 2021, Hilly received the Spirit of the Heart Health Equity Champion Award from the Association of Black Cardiologists. He has worked with organizations like the ABC, the National Medical Association, the National Black Nurses Association, the National Hispanic Medical Association, and the National Minority Health Alliance on initiatives to eliminate disparities and improve health outcomes over many years. Our panelists are going to present, and then we're going to have 20 minutes at the end of the webinar for your questions. So please post your questions using our Q&A feature, and we're going to answer them at the end during the Q&A session. And we highly encourage any and all questions, so please participate. Additionally, we've enabled live transcription of this webinar. So if you'd like to enable this feature, please follow the instructions on the current slide you see. Now, before I introduce our first speaker, we'd like to ask you 3 polling questions. And the first question for today is a quick yes or no question. We want to know, do you know your cholesterol numbers? Click yes if you know, or no to submit your answer. Okay, let's close the poll and see what we got. 81%. Congratulations. Wow. Okay. So 1 in 5 of you, around 19%, said no. Um, so a lot of people know their cholesterol numbers. Congratulations. But 1 in 5, including myself, don't know. And that's actually not too uncommon. But it's really important for everybody to know their numbers. So congratulations to those of you guys that know. And we're going to make more of a case for everybody on here to know in the future. So our second question is, how prevalent do you think familial hypercholesterolemia, or FH for short, is in the United States? Do you think it's 1 in 50 people, 1 in 250, 1 in 500, or 1 in 1,000? So click on the response that you think is right to submit your answer. Okay, let's close the poll and check it out, see what people said. 1 in 50, almost half of you. Then another quarter, 1 in 250, another quarter, 1 in 500, and 5% of you said 1 in 1,000. So based on the polling results, and the fact that many of you have probably never even heard of familial hypercholesterolemia, you'll probably be surprised to learn that in the prevalence of FH in the US is estimated to be 40%, or 1 in 250 adults. So I am impressed because we had a higher, I think, than the average, but good to see, and we're going to learn more about this today. So our last question is, approximately what percentage of the US population has a high level of LP little a, or lipoprotein A? And this is a type of fat in the blood that can increase the risk of cardiovascular disease. It's a variant of low density lipoprotein, or LDL, which is often called bad cholesterol. So you can submit your answer now. And let's close the poll and see how people voted. Okay, so the overwhelming majority said 20%. And then after that, 34% said 40. So a good job. According to current research, around 20% of the US population is estimated to have high levels of LP little a, and that means that roughly 1 in 5 people have elevated lipoprotein A levels, considered a significant risk factor for cardiovascular disease. So to help us understand what these numbers mean and why they're so critical, in addition to learning more about FH and LP little a, I'm thrilled to turn it over to Dr. Rodriguez, who will provide an overview of cholesterol, review the existing research, and comment on current research in the field that we should all be aware of to improve our heart health. Welcome, Dr. Rodriguez, and thank you for joining us.
Thank you so much, Sue. And I'm delighted to speak with you today about my favorite topic, LDL cholesterol. I'm going to go ahead and share my screen. And let's share this one. And let me go into, and I'm just checking with the team that the correct slides are, or do you need to swap views?
Swap displays.
Swap displays. Correct? Good?
That's great.
Okay, everybody. Well, delighted to be here. My name is Fatima Rodriguez, and I spend a lot of my time doing research around cholesterol, but my clinical job is to lead our preventive cardiology section at Stanford. And we spend a lot of time treating patients with dyslipidemia, whether that's inherited or acquired, and people at risk or with heart disease. So we have a few learning objectives for today. First, describe the role of cholesterol and how it affects heart health. We're going to learn about the different types of cholesterol and what they mean. We keep hearing about the different types. Does the ratio matter? Identify ways to reduce cholesterol through a combination of lifestyle and medications. And Hilly will really do most of this, which is obtain tools for shared decision-making around cholesterol with your care team. And we hope to have a lively discussion, so please put your questions in the chat. So cardiovascular disease is the leading cause of death in the United States, but 80% of heart disease, I'm sorry, I'm going to stop sharing because it looks like my slides are advancing on their own. Just give me 1 second. And I've done so much Zoom that I know exactly what's wrong, so that's good. I'm going to reshare my screen, and hopefully the issue has been resolved. Everybody seeing the correct screen?
Just
Yes?
your displays again.
Swap displays or good?
Yeah. Yep, swap displays.
Okay.
Thank you.
Okay, so let me go back to where I was. So cardiovascular disease is the leading cause of death in the United States. But 80% of heart disease is preventable by early identification of those at risk and promptly beginning therapies. Black adults are more likely than to die from heart disease, twice as likely as compared to white adults. There are huge issues around health equity, and Hilly has done a lot of work around advocacy for the Black populations. When we think about the role of preventive cardiology, it's really a spectrum. There's primordial prevention, or the prevention of cardiovascular risk factors, and that really starts generally early in the life course. And you do this by changing the communities in which individuals live in. Primary prevention focuses on disease prevention before the occurrence, and this is by controlling risk factors for those who are already established. What we do a lot in clinical medicine is we focus on folks who've already had cardiovascular events, and we try to prevent the recurrence. So you'll hear that term as secondary prevention or high risk secondary prevention. But there's a new area, which is subclinical atherosclerosis or prevention 1.5. So this is signs that you've already had plaque buildup in your body from a cause of LDL cholesterol in things like coronary artery calcium or other types of plaque, even though you may not have symptoms. And we know that makes you at higher risk of heart disease. The American Heart Association has set a set of 8 health behaviors and guidelines that if you follow these, it's called you're essentially doing all the right things to prevent heart disease. And many of these are modifiable, and therefore there are a set of health behaviors. Again, your diet, your physical activity, not smoking, and getting adequate sleep. So sleep was recently added. And then the health factors, and this is really where knowing your numbers matters. Body weight, blood lipids, which is really what we're going to focus on, blood glucose, and blood pressure. In addition to that, the psychological health cannot be ignored, and we know that that really affects how you experience health, as do the social determinants of health. So how common is high cholesterol? So about 38% of American adults have high cholesterol according to recent estimates, and that's with total blood cholesterol values over 200 milligrams per deciliter. So very common, and again, I'm sure if you don't have high cholesterol yourself, you know of somebody who has high cholesterol. And this is really important because this is a very modifiable risk factor for heart disease. So let's get a little bit more granular. What is cholesterol? So cholesterol is a waxy fat-like substance that is found in all your cells in the body. And plasma cholesterol is transported in complexes called lipoprotein. So that's where you hear low-density lipoprotein cholesterol. And lipoproteins that contain apolipoprotein or ApoB, they convey cholesterol into the artery wall. And these are the ones that are really dangerous for heart health. And these are things like low density lipoprotein, also known as, again, the bad cholesterol. In this case, it really is the bad cholesterol, VLDL, and then something that we'll talk about, lipoprotein A cholesterol. Again, they have that atherosclerotic particle, the ApoB. So where does cholesterol come from? So cholesterol is actually made in your body by the liver, but also comes from dietary intake. And again, cholesterol is transported by the main lipoproteins, low density lipoprotein, high density lipoprotein, sometimes known as good cholesterol, lipoprotein A, and triglyceride rich proteins. So these are the numbers you may get in your cholesterol panel. So triglycerides transport and store energy. There's steroid hormones, bile salts from cholesterol. They help digest fat, used to create energy and synthesize cell walls. So you may ask, it sounds like we need some cholesterol. And again, your body actually needs a very, very, very small amount of cholesterol to function normally because a lot of the cholesterol is already inside of the cells. So how does cholesterol result in plaque? Obviously, it's a very complicated diagram. But we used to think that, again, plaque just built up and then eventually you had a heart attack. But we know it's actually much more complicated than that. And something called vulnerable plaque, where it's when the plaque kind of flicks off and then causes all the platelets to come together, and that ultimately can result in a myocardial infarction. So we asked in the polling questions, 81% of you know your cholesterol profile. So what's the ideal cholesterol profile? So the ideal cholesterol profile is a total cholesterol under 200 milligrams per deciliter. So that's what's considered, normal, even though I would argue that moving to lower ends is better. LDL, or the bad cholesterol, under 100 milligrams per deciliter if you have no risk factors for heart disease. But once you start having risk factors, then it's better to be even lower, really under 70 milligrams per deciliter for anybody with high risk features. So the HDL cholesterol is a little bit confusing. So we've heard it's a good cholesterol, and a lot of patients actually want to raise their HDL cholesterol. But a lot of data has shown us that there's no real appropriate pharmacological way to raise that number, and it really is a marker for things. Ongoing research has shown us that low HDL, again, is a marker for people at risk, and very high HDL can actually start becoming dangerous, and maybe there's dysfunctional. Triglycerides, so I love triglycerides in the clinical setting, not so much because they're drug targets, but because they help you understand what the patient is eating. They're very sensitive to diet. They're very sensitive to the insulin your body's producing. So when I see high triglycerides, again, that usually correlates with a metabolic syndrome, diabetes, or bad dietary decisions. Again, the ratio, which we used to talk about many years ago, is something I don't talk about at all clinically. And again, we tend to focus on LDL cholesterol and modifiable factors like triglycerides, which actually respond very well to diet. I want this really to be the main take-home point of everything I'm going to discuss with you today, and it's really that LDL is the major player. LDL cholesterol is linked to coronary artery plaque linearly. So this is a lot of data. So these are just names of studies that have looked at statins versus placebo. And again, there is a linear association. This is very clear. The higher your LDL cholesterol gets, the higher your risk of cardiovascular events. However, many people with high cholesterol are unaware of their risk, and that's why we really want to get those numbers up to 100% of you knowing your numbers. I often also think of cholesterol like smoking. It's really exposure over time. So this is something you're exposed to all your life, especially if you have a severe form of high cholesterol called severe hypercholesterolemia, shown here in the red. Again, just more years of higher exposure. And this is why we really want to treat early. Again, some genetics, higher cholesterol left untreated. And then we can see that lifelong low LDL is really the ideal case to have less exposure. So very similar, and think about it, it's not really one LDL value now, but it's your LDL over time. And the goal is to minimize the exposure just like we do with tobacco. So we ask in the polling questions about familial hypercholesterolemia. I'm amazed that some of you may know about this. Again, I have a clinic that has expertise in cholesterol, so we see a lot of patients with this. It's not that rare. It's actually one of the most common autosomal dominant genetic disorders. And this is caused by a mutation, typically in 3 genes that impact cholesterol lipoprotein metabolism. It has a prevalence of 1 in 250, so 0.4% of the population, which again is quite a large number, more common in certain populations. And it's caused by mutations of LDL synthesis, again, LDL receptor, PCSK9, ApoB, and it results in high LDL and premature coronary disease. So if you see a young patient and they have heart disease early in their family, it's really important to make sure you're not missing this. Because again, these individuals tend to have higher exposure of high cholesterol over time, and this can really be helpful to screen family members to prevent heart disease. The data shows us that 50% of untreated men that have FH would have a heart attack by age 50. And once you identify an individual with FH, it really becomes a family disease, and you have to screen family members. First degree family members have around a 50% chance of also carrying the mutation. But again, the good news is that FH is a winnable battle. If you treat patients early, you identify them, you reduce morbidity and mortality by 80%, highly cost effective with both statins and other therapies. We have over 20 years of data of FH in children, again, showing that even kids with very severe forms of FH who are treated with statins do very well. And you can see here in this, they can really have freedom from cardiovascular events once they're treated, as shown here, and have very normal life expectancies, unlike their parents who are untreated. So very important to treat individuals early. So some of you have heard about the new kid on the block, or lipoprotein A. So what is lipoprotein A? So lipoprotein A is apolipoprotein B containing particle that's similar to LDL that is associated with increased cardiovascular disease risk. We have a lot of very strong epidemiological data and Mendelian randomization data showing that the higher your lipoprotein A, the higher your risk of cardiovascular disease. Yet, we're still undergoing studies, clinical research studies, to see does lowering lipoprotein A lower your risk of heart disease? And there's a lot of ongoing research about this. It's very useful clinically because it can help us understand who is at risk of heart disease and can help us be more intensive in treating the risk factors we know they have. So this was one of your questions. What is the prevalence of high lipoprotein A? And sometimes for this, the units really do matter because there's one unit nanomoles versus nanomoles per liter versus milligrams per deciliter. So they have just different cutoffs. Generally, elevated lipoprotein A is considered over 100 to 125 nanomoles per liter, which is roughly around 50 milligrams per deciliter in the other assays. It varies by geography. So based on recent estimates, around an average of 20% of the population has what we would consider elevated levels. And what this figure here shows is that this really has to do with the migration of the lipoprotein A gene. And again, this results in differences worldwide with lipoprotein A plasma levels. So higher prevalence of high lipoprotein A of those from African descent and South Asian descent as shown here. So again, I mentioned we don't have a specific treatment for lipoprotein A. So is there a utility in even checking lipoprotein A? And this is a discussion I have often with patients and primary care clinicians. So again, we know this is a genetically determined causal and highly prevalent risk factor for heart disease. So why would we check it now if we don't have a specific treatment? Unlike LDL cholesterol, this is really something that you can check now, check one time and you're done. It's just kind of a risk enhancer. Once we have therapies available, we would want to check it more than once. But the reason that this is helpful is that it can make you aware of your higher risk of heart disease, and it can inform shared decision-making with your clinician around, should I be more intensive in lowering my blood cholesterol, my blood pressure, and it can help us also screen family members who are at high risk of heart disease. So how can we reduce the risk of heart disease? And this is ASCVD is an acronym for atherosclerotic cardiovascular disease, because we know that the plaque that builds in the arteries of the heart is also the plaque that builds in the arteries of the neck and the legs. It's really all one syndrome of atherosclerosis. And the answer again is very simple. LDL is the target. So if you had one thing, that's really what you want to target. And this is supported by very robust observational data, Mendelian randomization, a lot of randomized clinical trials and animal experiments. The lower the LDL, the better. So how do you do this? Step one for everything, especially for health maintenance, is lifestyle. So there's no substitute to a good lifestyle, no matter what drugs you take. And what we recommend in our clinic is really to focus on plant-based foods, fruits, vegetables, whole grains. Include foods as natural as possible. So anything that comes from a can, think twice about it, or highly preserved. Mono, polyunsaturated fats, olive oil tends to be preferred, especially this Mediterranean lifestyle or patterns. There's a lot of healthy fats like avocado, nuts, and seeds. Again, lean protein, beans, legumes, fish, chicken, rarely some lean red meats, and dairy can be a very common source of saturated fat, so opting for low-fat alternatives. But we've made cholesterol so confusing to the public, right? Here we have an article historical one from the Ansel Keys, again showing the importance of this low-fat diet that was the obsession historically, as you remember. Again, in the 70s, early 2000s, Ansel Keys' low-fat diet theory, he really postulated that it was cholesterol and fat that resulted in atherosclerosis and heart disease. But then more recently, we've seen this obsession with new diets, right, around cholesterol. And we talk about, eat butter, switch to keto diets, the good news. So again, there's been a lot of popular media around this. And what's the right answer? And we know it's not that simple, because there's a lot of things to be said about insulin and lower carb diets. But I think for the purpose of lowering LDL cholesterol, it is very clear that plant-based diets are helpful. I wanted to give just a shout out to one of my colleagues from Stanford. This is Dr. Christopher Gardner, who is a nutritionist and a researcher, prolific researcher here at Stanford in the Stanford Prevention Research Center, who just partnered with a filmmaker to make a very interesting documentary about identical 21 pairs of identical twins. And basically one of those twins is fed a healthy vegan diet, and the other one is fed a healthy omnivore diet. And then they followed them for 8 weeks to see what happened. Again, a fairly simple study, and these tend to be younger twins. And what they had their primary outcome in this 21 pairs of twins was LDL cholesterol. And you can see here that those who had a vegan diet, again, just in 8 weeks, had substantially lower LDL cholesterol. The omnivore diet was very healthy as well. And again, that is no surprise because in a vegan diet, there's really very limited saturated fat. That said, I do not routinely recommend a vegan diet. I do recommend dietary patterns that tend to be focused on evidence-based diets. And these are really Mediterranean type diets, DASH diets, healthy vegetarian, healthy vegan, if that's preferred. But I rather focus on dietary patterns as saying you can exclude this food group. And the reason is that I worry that sometimes these extreme diets are just not sustainable long term. So it's whatever diet works for you, and very simple things to eat whole foods as much as possible, vegetables as much as possible, and keep a protein to lean options. Activity is also extremely important. Again, we know that it helps everything. It helps not just your heart health, but your mental health, your bone health. And again, these are the recommendations from the American Heart Association. You want 150 minutes a week of moderate activity. And again, now we've also shifted the data. Instead of focusing exclusively on aerobic exercise, we know there's significant value in strength training, particularly as we get older. Muscle helps fight insulin resistance and burns more fat actually as you're metabolically inactive. So a question that I often get from my patients is, I don't want to take medications, but here's a whole bag of supplements that I got at CVS. Are these good? The short answer is save your money. Very few supplements are helpful for cardiovascular health. And this was a really interesting study that was run out of the Cleveland Clinic by Luke Laughlin. And what they did is that they randomized 190 participants across several interventions with the primary outcome of LDL lowering. And they used different kind of supplements that are advertised to lower your LDL cholesterol. And you can see here some familiar names, such as actually placebo, which means nothing, lowered cholesterol a little bit, fish oil, cinnamon, garlic, which was a brand name of garlic, actually raised cholesterol. And again, you can see turmeric, plant sterols, red yeast rice, which is actually a type of statin. And what you see here is that it's no comparison. The difference in LDL reduction with the rosuvastatin compared to placebo was 35.2%, and none of the other dietary supplements that are advertised to lower cholesterol really resulted in a significant decrease compared to placebo. So, and again, the adverse effects were no different across groups. So save your money, stay away from supplements in general, and if you need us to lower cholesterol with medicines, there we have good ones. And what are these good ones? So we'll just talk a little bit about statins, which many have heard about, which again is really the mainstay for lipid lowering therapy. So they all work the same, even though they're different classes of them. And they work by inhibiting the HMG-CoA reductase, which is an enzyme in the liver that synthesizes cholesterol. So the bottom line is it reduces the production of LDL from your liver. And the liver increases LDL receptor activity when this happens, and then it pulls more cholesterol from the bloodstream. So you lower your LDL cholesterols and reduce your cardiovascular risk. And there is a lot of very, very good data showing that these are safe and effective. But statins don't work in people who don't take them. So we've shown a lot of data that even people who are prescribed these for high-risk heart disease, the moment you stop being adherent to your statins, you're at higher risk of facing a cardiovascular event or even death. And there are disparities in who's likely to take these medications. The more you take them, the more the benefit. And this really goes back to the principle of lowering LDL over time and how important that is. Many individuals are worried about side effects that they've heard about from statins, right? And this is just a study showing that in randomized control studies, when you give someone a placebo or a statin, so placebo is an inert pill, the report of side effects is really, you can just see it is no difference, as shown here. They're really superimposed. But because there is an expectation that statins may cause side effects. That said, for whatever reason, whether you're intolerant or you cannot take statins, there are different things that your doctor can do. What we do in our clinic is that we can use statins with lower risk of side effects. I have a strong preference for rosuvastatin, which is generic, very effective, stays in the system for a while. There's lower potency statins like fluvastatin, pravastatin, even just alternating dose. Again, every other day statin is better than no statin. And now we have a growing array of non-statin therapies. So if you either can't or won't take a statin, there are many alternatives to that. And here are just some examples of those. So ezetimibe is a generic medication. It's approved in 2002, so it's been around for a long time. It's a cholesterol absorption inhibitor, so it acts in the gut, so it prevents you absorbing cholesterol from your diet, and it can have a very potent effect, especially in synergy with a low-dose statin. So that's usually what I start with. There are medications called PCSK9 inhibitors, and these are particularly helpful for people with very high cholesterol or at higher risk, and those are the two options, and these are injections that you can do every 2 weeks yourself at home. There is an oral combination pill with bempedoic acid and ezetimibe, so again, those are oral options. And there's a medication called inclisiran, which you would get injected at the clinic every 6 months, and that is, again, very effective in lowering cholesterol. So if all of this to say is that there are very good non-statin options. And in general, how much are you going to lower your cholesterol? So it really depends on what you start with. Diet alone, usually you can't get more than 10 to 15%, especially if your risk of heart disease is more genetic, meaning your body's making too much cholesterol. Statins are very effective, can reduce cholesterol often by 50%. Ezetimibe, Zetia, a little less, 18 to 25. Bile acid sequestrants I usually don't use, but those again can be helpful in some cases. And again, you can see here the other medications. So another question that I get asked all the time is it dangerous to have too low of a cholesterol? How low can you go? And the answer is you can really go very, very low and have no issues at all, no concerns around cognitive function, adverse effects. And again, this is a complicated slide, but again, showing that in some of these clinical trials that we've done, some people have gotten LDLs under 10. And we really see no threshold to the benefit. You can see that even at very low levels under 10, ultra low LDL, there's still a reduction in cardiovascular events. So particularly for very high risk individuals, the lower seems to be better. So you just do as low as tolerated. Whatever the approach is, there's a clear benefit of LDL reduction. Your benefit is greater with your higher the risk. So both primary prevention and secondary prevention. And on average, every time you reduce your LDL cholesterol by 40 milligrams per deciliter or so, your risk of heart disease falls by 20%. So very dramatic impact. And again, the principles really here are simple. The lower the better, the faster the better, the longer the better. And again, these are true across primary prevention, meaning you don't have heart disease yet, but you may have risk factors, and secondary prevention. Once you have heart disease, you're preventing recurrence or progression. And I'll just very briefly mention, a resource that you can use, and Haley is going to discuss around the Family Heart Foundation and their amazing group and resources that they have to really help patients advocate around their cardiovascular risk as it relates to both high LDL, but also high LPA. I would just caution online resources that are not vetted. So you want to make sure you're using resources that are part of trusted organizations like the American Heart Association, which myself and Haley and others are volunteers. And there's a lot of patient information. So again, the American Heart Association, the American College of Cardiology have a lot of patient language around this. So here's an example from the American Heart Association. What does my LDL cholesterol number mean? And again, I would use these sources to help us understand our numbers and our risk information. So too much LDL can increase your risk of heart attack and stroke. And again, most patients are asymptomatic. They can go very closely around who should get cholesterol checked and how often. So I encourage you to use those resources. And now I'm going to turn it over to my colleague, Hilly, to go over more resources from the Family Heart Foundation. Thank you so much for your attention. I apologize for the technical glitch.
Wonderful. Well, thank you so much, Fatima and Sue. I just want to say a big thank you to you and the team at the Alliance for Aging Research for the invitation to participate today and for organizing this webinar. We were really honored that you would include the Family Heart Foundation. So on my next slide, I wanted to introduce the Family Heart Foundation to those of you who may not have heard of us before. So we're a nonprofit patient advocacy organization that was founded in 2011. And the mission of the organization is to save generations of families from heart disease through timely identification and improved care of the two most common inherited cholesterol disorders. And so that's familial hypercholesterolemia, which you heard a lot about from Dr. Rodriguez, and also elevated lipoprotein a. FH occurs in about 1 in 250 individuals and has a diagnosis rate of only about 30%. And high lipoprotein a occurs in about 1 in 5 individuals, so incredibly common, but the diagnosis rate is only about 1% because most people are not screened for high Lp(a). We focus on research, advocacy, and education to drive change and empower patients. Our website is below. And I would say if you've ever been told that heart disease runs in your family, we really are a home for you. So check us out. We have a lot of great tools and resources and really focus on genetic forms of lipid disorders and cholesterol disorders. So I want to highlight on the next slide, the next couple of slides, a couple of resources for folks that have joined the webinar today. If you took the survey, and I was very impressed that 80% of the folks joining us know their numbers, which is usually, it's much lower than that. But if you, one of those 80% and you know your numbers, but you're not quite sure of the destination or what your LDL cholesterol should be or how you want to get there, we launched a website called the LDL Safe Zone on September the 30th, and it has lots of tools, resources, videos, infographics that can help assist you on your journey to the LDL Safe Zone. So I would encourage you to check that out. The website is below ldlsafezone.org. So if you know your numbers and are looking for support on how to get where you want to get to, I would check out the LDL Safe Zone. Now, on the next slide, if you're one of the 20% who hasn't been tested recently for your LDL cholesterol, or maybe you have somebody in your family who hasn't been tested recently, we launched a program called Cholesterol Connect, also on September the 30th. And this is free at-home testing program that will test you for a full lipid profile, so LDL, HDL, triglycerides, total cholesterol, as well as something that usually is not included in a standard lipid panel, and that's lipoprotein a. So this is free. You don't have to have insurance. It's absolutely free. The website is below cholesterolconnect.org. Anyone can go there and order a test kit. And what's a little bit unique about this program is it's not only the screening, but we also try to pair it with support through our Care Navigation Center, which I'll talk about in just a minute. On the next slide, on the lower right-hand portion of the slide, you see a QR code. And so if you take out your phone and take a picture of that, that will take you right to the website. On the lower left is a picture of what the test kit looks like when it shows up at your house. And at the top is once you unpack the test kit, it really is just a very simple finger stick. And then within a week, we'll send you the full lipid profile as well as your lipoprotein . So again, I would say if you haven't been tested recently, or if you have family members that you're worried about or who haven't been tested, please go to cholesterolconnect.org and order a test kit. And then on my final slide, what kind of makes this program unique is we pair it with our Care Navigation Center. So we have 3 care navigators that you see below, one who is a genetic counselor, one who's a nurse practitioner, and one who's an expert in public health. And so this is, it's not chat GPT, it's not artificial intelligence, it's real life human beings who have a lot of resources, tools, educational materials, and can help support you if you end up with a high LDL or a high lipoprotein little a. They can provide a lot of resources and support. So with that, I think we're going to go to your questions. But again, cholesterolconnect.org, and I would really encourage everyone, if you haven't been tested recently, to go ahead and get tested and order a test kit. Sue, I'll
Great.
turn it back to you.
Thank you so much, Hilly, and thank you to Dr. Rodriguez. And now both Hilly and Dr. Rodriguez are going to answer any questions you might have. As a reminder, you can submit your questions via the Q&A feature that we have. Our first question is, you discussed the importance, Dr. Rodriguez, of lowering LDL-C. Is lowering LDL-C more important than the other numbers?
Great questions. So yes, I think that's a good summary of what I was saying in a very long-winded way. We have made analyzing those numbers complicated, and I think that's why there's so much confusion. We used to talk about the ratio, if you remember. We say, if the HDL is good, that's okay. And I think that has now resulted in a lot of undertreatment of LDL cholesterol. So absolutely, if you had one number to pick, you would definitely only focus on LDL. There's a caveat to that. Sometimes when you get your cholesterol tested, you actually usually don't get your LDL measured directly. I do in my clinic, but that's important to me because I'm working on very precise numbers. Usually it's calculated, right? So sometimes, again, if your triglycerides are very high, it could result in errors in the LDL calculation and numbers. So, and that is one question that often comes up is, should I be fasting? Mm-hmm. And for most people, you do not need to be fasting. So that should not be a barrier to getting your LDL checked. The exception is, again, when triglycerides are high. So if you know your triglycerides run high, that will affect your cholesterol numbers. And your triglycerides are very sensitive to your fasting or not fasting state. We also don't tend to treat triglycerides anymore with medications until they get very high. So in general, triglycerides, you really want to do lifestyle. You want to control, if you have diabetes, control those. And LDL is what you really focus on. HDL, if somebody's telling you there's a treatment for that in terms of medications, that is incorrect. There is no treatment for HDL in terms of raising it. It's just a marker.
Okay, thank you. I want to let everybody who's tuning in know we are recording this, so it's a lot of amazing information. And if you want to go back and retrace steps on any of the slides or these great comments, you'll be able to do that. So our next question is sort of a two-parter here. What foods help to decrease LDL? And then what is the optimal level for Lp(a)?
Great. So I think for diet, it is very clear that vegan diets are the ones that really result in the lowest LDL. Again, those have some issues for other reasons in terms of how long they're sustainable. We don't want individuals to be B12 deficient or eat low protein diets. But absolutely, as we saw in that twin study, as we've seen in a lot of the very extreme vegan diets, it is vegetables, things that are low in saturated fat, result in the lowest LDLs, high fibers. And for your second question, so LPA, again, is genetic. So this is not something that you should feel upset at yourself for. If your LPA is high, there's nothing you're doing. That's just the genes you were born with. But genetics is not destiny. So we know that you can lower your risk even if your LPA is high by targeting the other risk factors that we know are modifiable. And just like LDL cholesterol, it looks like the lower the lipoprotein, the better. But we really start seeing high risk at levels over 50 milligrams per deciliter. But again, it is a continuum. So the lower, the better.
I want to go with a follow-up question about food since we're heading into the holiday season and, folks like to have maybe a little bit more in the way of Christmas cookies or, indulge here and there. What can you tell folks about sugar, about, maybe just when you overindulge a little bit, just what, this is an interesting time for us to have this webinar, right? Because health is not exactly what people think about when they're heading straight into the holidays. And then also, I guess my other question is around alcohol consumption.
Great question. So very simple. And I say this in clinic all the time. If you're going to eat something that you know is not healthy, make sure it's delicious because it's not worth the calories, right? So, and it's okay. But what I like to see is like be mindful about it. I'm going to enjoy this delicious treat. It's Christmas, but I'm going to eat maybe half the portion I would have just if I was being mindless about it. So that's just the caveat. Alcohol, very interesting. So alcohol and cholesterol. So alcohol will lower or increase triglycerides. There's no amount of alcohol that is good for you. So that is a myth. But again, 1 glass for women, 2 for men in terms of like wine or beer is usually the limit. So again, it's okay in moderation. It's not good for your heart, but again, just be mindful about it.
And then Hilly, do folks who have familial hypercholesterolemia need to take special care, or is it sort of the same rules apply as long as you're managed?
I would say the same rules apply, Sue, although when you're starting with a much higher level of LDL cholesterol, so oftentimes people with FH have an LDL over 190. So we'll see a lot of people in our community that are 200, 250, 300. It's tough with diet to get to a normal level of LDL cholesterol. And so really you'll need to rely on some of the other options. Unfortunately, there are just a lot of options in the toolbox now for lowering LDL cholesterol. And maybe to come back to the Lp(a) question for a moment, Dr. Rodriguez did a great job of saying we've gone out of our way to make cholesterol confusing for people. With Lp(a), we actually have 2 different assays. And so depending on how you get tested, you can either get tested in milligrams per deciliter, and that has one range of what's normal and what's high. And then there's nanomoles per liter, which is the favored, but that also has a different range. And so in Cholesterol Connect, we test it via nanomoles per liter, and under 75 would be normal, over 125 would be high. But it's important if you've had it tested before and you get it tested again, oftentimes we'll find people who get very concerned because they'll say, oh my God, my Lp(a) has gone up 2-fold since the last time I had it tested. And it's usually very stable. And oftentimes what happens is you've had it tested previously in milligrams per deciliter, and then you get it tested in nanomoles per liter, and all of a sudden it looks like it's gone up. So we're not off to a great start with making Lp(a) simple, but it's important to know that there are 2 different assays.
Thank you. Our questions just seem to explode. So I'm going to try to move us along here. So the next question is, does fatty liver disease cause high lipid numbers, or is it the other way around?
Great question. So this is often statins are metabolized in the liver, so I'll often see this error where people are stopping statins or cholesterol medications because of fatty liver. So fatty liver itself does not cause high cholesterol. It's the opposite. So high cholesterol, and usually like insulin resistance and metabolic syndrome, is associated with fatty liver. And now I think the preferred term is like metabolically associated steatotic liver disease, which just make it very complicated, or MASLD. So you may hear this term. Nowadays, it's the #1 cause for need for a liver transplant. So just
Wow.
fat in the liver. So in those patients, again, we just have to be extra aggressive in treating cholesterol levels. And usually, again, we see that the liver numbers get better as the cholesterol comes down.
Okay. Good to know. Thank you. Next question. My cardiologist doesn't test Lp(a) because it's not treatable. How do I talk to my doctor about requesting these tests, and how often should I get them?
Billy, take that one because I test all my patients, but I have a biased panel.
Yeah, I think if you go to the Family Heart Foundation, we have a lot of different infographics and resources on Lp(a) and how to have that conversation with your cardiologist. And I think ultimately it's your health, taking charge of that and requesting that they test for it is key. If ultimately at the end of the day they refuse, then I think Cholesterol Connect is a great option because you can order the test kit, you can test it yourself, and get peace of mind. And it really is something that you should, as Dr. Rodriguez said, test at least once in a lifetime because it is very stable. And until we have therapies available for actively lowering it, usually if it's high, it's high. If it's low, it's low. But if you're one of the 20% with a high level of Lp(a), it's definitely worth knowing about it and doing something to adjust all your other risk factors.
Excellent. Thank you. Is CVD reversible?
Great question. So plaque, and again, I'll interpret that as plaque in the arteries. Yes. So there are some studies where they actually put ultrasounds and catheters in the heart arteries and start measuring regression. So that's called plaque regression or plaque stabilization. And again, the best way to do that is by lowering LDL to very, very low levels. Yes.
Okay, that's good to know. Is there a relationship between high cholesterol and dementia? Oh, Dr. Rodriguez, for some reason we can't hear you too well.
Oh, can you hear me now?
Yep. Oh, you froze.
I would say there definitely is, Sue, a link between high cholesterol and risk of dementia because it's probably not surprising. If the cholesterol is clogging up your arteries, it can also clog up the arteries that take blood to your brain. And so some of the encouraging research with statins is actually there's a lower risk of dementia in some of the trials that have been reported out with statins. And so there are lots of benefits of lowering your cholesterol on the cardiovascular side, but also for brain health. It's important as well.
That's right. I know American Heart and the Alzheimer's Association have worked together on some of these issues, which have been wonderful to see. So do you have a recommendation, Hilly, for testing healthy children for FH?
Yes, so the recommendation right now is that every child between the age of 9 and 11 should be screened for their cholesterol. And that really is the best way of picking up any sort of genetic risk. If there's risk in the family, so if you know of a father or mother, sister, brother, somebody who has had a heart attack early in life or who has premature cardiovascular disease, the recommendation is at the age of 2 that a child be screened. And unfortunately, the recommendation of between 9 and 11, only about 20% of kids are actually tested, and it's really a simple finger stick test. And so really anybody between the age of 9 and 11 should be tested, but if there's a family history, age 2.
Okay, thank you. Next question is, I went to Cholesterol Connect to register. Oh, wait. Let me see. I went to and the state drop down does not include Rhode Island. Does that mean the test is not available?
So there are a couple of states, New York is one, and I think Rhode Island is the other, where the state laws do not allow people to test at home for their lipid values, which in this day and age of empowering people to manage their own health is always kind of surprising. So we've been working with our partner testing company, Endless Health, to advocate with these states to try to get that overturned. And so I would say if you live in a state where it's not available, the best option is to talk to your healthcare practitioner and really encourage them to test. Most managed care companies and insurance companies will cover the cost of the test, but it's worth having a conversation with your physician.
Terrific.
And
Interesting.
Sue, I'm back if you need me because I had unstable internet.
Okay, thank you. So next question is for you. If I begin taking a statin, will I have to stay on medication for life, or will I be able to stop taking medication when my LDL has been lowered?
Great question. So I think this is one of the reasons people are hesitant to start statins. The answer is it's a lifelong problem, and you will need to take a medication lifelong. When you stop the statin, the LDL very quickly rebounds back up. If just taking a daily medication is so cumbersome or so challenging, there are, again, some of these injectables that you just inject once every 6 months, for example, inclisiran are potential options for those at the highest risk of heart disease.
Okay. Are there side effects of statins that I should be concerned about? And somebody also had a question about whether or not they can raise blood sugar as a side effect.
So that is a true side effect in terms of the statin side effects. If you go on Google, which I highly discourage, everybody sort of attributes everything to statins, right? Like, I'm in a bad mood today, must be the statins, all this stuff. And the answer is that statins have one major side effect, and that's that they make you live longer, and that is key. But the true side effect that there is a signal there for insulin sensitivity. So if you have a tendency to have diabetes and you have prediabetes, that insulin profile, it can bump you maybe like a little tiny bit. But again, the benefits of being on the statin for your cardiovascular risk are completely worthwhile. But there is a slight increase in your threshold values there. Other side effects, and again, because I have a specialized lipid clinic, there are some individuals that really cannot take statins in terms of the muscle aches or tendon aches. Those are very rare and very rare, less than, 1 in 100,000 serious muscle problems in terms of muscle inflammation where you can get very sick. But again, you rarely see that in everyday practices.
Okay.
I would say, Sue, the other key issue is that not every statin is the same. So we find in our community a lot of success. If you've tried one and you've had a side effect, it's not worth giving up. If you try another one, oftentimes you'll be able to tolerate that. And if statins are totally off the table, as Fatima mentioned, there are 3 other classes of drugs that have been proven to lower LDL and lower cardiovascular risk. So what's great is now there are a lot of options out there.
I think
it almost doesn't matter, how you lower the LDL. Like I think all our data is just showing us lower it. Statins have been around for a while, and they have this anti-inflammatory effects as well. So if you're able to tolerate a statin, that should be your mainstay. And again, like Hilly said, the newer statins, like rosuvastatin, they tend to be very well tolerated.
And I think that's a great point is not to give up and go back to your doctor and have conversations. My husband does have CVD, and he was on one statin for a number of years, did experience muscle ache issues. He's a runner and switched, and it improved substantially. So good. Next question. What is the importance of the ratio of triglycerides and HDL LDL?
My recommendation would be to not worry about ratios because it can get very confusing. And again, triglycerides vary a lot. So if I had a lipid panel fasting versus, a couple hours later after a meal, your triglycerides are going to be very, very different. Now, the high triglycerides, low HDL is a marker, for metabolic syndrome and insulin resistance. So that's how I use it. It kind of helps me get a sense of what are you eating, what's your insulin profile. And we tend to find that our patients with diabetes tend to have low HDL and higher triglycerides because of their insulin patterns. Statins actually lower triglycerides as well, around 25%.
Okay. If you have a high calcium score, should you take a statin, and is a high calcium score reversible?
Great question. So I mentioned it in one of my slides that there is it's a kind of continuum. So I consider people with calcium, so that's called subclinical atherosclerosis, you're at higher risk of heart disease. And we know that if that number is above 300, your risk is actually pretty similar to that of someone who's already had a cardiovascular event. So yes, I would say that in those cases, you should be on a statin and you should target your LDL cholesterol to be under 70 milligrams per deciliter, maybe even lower.
Okay. And then let's do the last question because we're about to wrap up. Somebody asked, can I indulge a little if I take statins? We sort of covered this. Someone wanted to know, are there cheeses that are better than others? I think this is a good holiday question as we go into, receptions and cocktails and all that. There are differences in cheeses, right? Or no?
I mean, there are low fat cheeses. Remember the pearl, make sure it's delicious and just eat a little bit of it.
Okay.
All things in moderation.
All things in moderation. All right. Well, I really want to thank our panelists today. Again, I want to thank our sponsor, Amgen, on behalf of the Alliance for Aging Research and the Talk Nerdy program. We hope you found this webinar helpful and insightful. Again, we're going to be sending out a link to those who attended and those who weren't able to make it to us today. We wish you all a healthy, safe, and happy holiday season and new year. Thanks so much for joining us, and have a great rest of your day.